Okay, so to pick up where we left off from last video, today we're going to go over the pathology section. I'm going to be focusing on hemorrhages and ischemic events mostly. Hemorrhage. Intracranial hemorrhage is most usually called germinal matrix hemorrhage or SubEpendymal hemorrhage because that's the germinal matrix area is also called the subependymal area of the caudothalamic groove. Once that breaks through the ventricular wall, it becomes an intraventricular hemorrhage. It is the most common pathology, neurological pathology in preterm neonates. It occurs in approximately 50% of premature neonates. Some studies state stats that are lower than that, others that are a little higher. 20 to 25% of these neonates are asymptomatic. That is why screening ultrasounds are ordered on these babies to rule it out. The bleeding, like I said before, originates in the germinal matrix or the caudothalamic groove. The pathophysiology of these bleeds is thought to happen because of an impaired cerebrovascular autoregulation. In term babies and in adults, we have a very good system that maintains adequate and stable cerebral blood flow. The brain is very sensitive to an over and underperfusion. However, in preterm neonates, this cerebrovascular autoregulation is impaired. Thusly, any rapid changes in blood pressure can lead to over and underperfusion of the very delicate capillaries in the germinal matrix, which causes hemorrhage. So, by the first week of neonatal life of the preterm infant, most of the hemorrhages have occurred. So, by 96 hours, 90% of all hemorrhages have occurred, and 80% of the grade 1 bleeds then progress to become grade 2 bleeds. This is why these serial screening sonograms are so important. First, they detect them, and secondly, they can detect if they progress. Here's a chart of the occurrence of bleeds in the first 3 days of life. So on day 1, 50% of all bleeds that are going to occur. By day 2, 25% of these bleeds have occurred, and by day 3, 15%. So risk factors. As I said in the previous video, prematurity is the number one risk factor for subependymal hemorrhages in these babies. Any baby born before 32 weeks of gestational age and under 1,500 grams is at an increased risk. Rapid fluctuations in blood pressure, which has to do with cerebrovascular autoregulation. Rapid changes in blood volume. So even if they give a baby a fluid bolus, if it's too fast, that could predispose the baby to hemorrhage. One study found that transfer from outside facilities had an increased risk of those babies developing hemorrhages. Underlying coagulopathies, respiratory distress, which is very common in premature infants since their lungs are underdeveloped, and hypoxic ischemic events. The standard grading system for subependymal and intraventricular hemorrhages has 4 grades. The first grade is the least severe, and it is maintained to the germinal matrix and subependymal region, and usually measures a centimeter or less. Once that blood breaks through the subependymal lining or ventricular lining and goes into the ventricle but doesn't cause dilation, that's a grade 2. A grade 3 is the same as a grade 2 with the sequential cause of ventricular dilatation. So you have the blood breaking through the ventricular wall, going into the ventricle, and causing ventricular dilatation or ventriculomegaly. And grade 4 is parenchymal hemorrhage. Though before they used to think that parenchymal hemorrhage was caused by blood, a grade 3 breaking through the lateral ventricle wall into the brain parenchyma, it is now believed to be caused by venous infarction. So increased pressure from the blood within the ventricles can cause decreased venous return, which can cause an infarction, and then necrosis and liquefaction of the tissues around the ventricles. Okay, so grade 1, it's limited to the subependymal region, so also known as the germinal matrix area. It is typically less than 1 centimeter, and if it does not progress to a greater degree, the outcomes of these babies is similar to neonates that never developed a bleed. So neonates that are born around the same gestational age who do not develop bleeds and do develop bleeds typically have the same outcomes. And as I said before, 80% of grade 1 subependymal hemorrhages progress to a grade 2 or higher. So this is a gross anatomy slice of a preterm neonate's brain. You can see it's very smooth, not much sulci or gyri. Here you have the sylvian fissures. Here's the bleed. So you got your subependymal region, lateral ventricle, and here you can see the bleed. So the clot's right there. You can see it's not going into the ventricle. And here's a sonographic image of the same type of bleed. So right here you have the bilateral lateral ventricles. This echogenic structure right here and this echogenic structure right here are subependymal hemorrhages. And then in a parasagittal view, you see right here. So thalamus, caudate nucleus, and then the clot. The ventricle is clear, just anechoic fluid. And here you can see the beginning of the Cory Plexus. So for a lot of beginning sonographers, they might see a lumpy or bumpy Cory Plexus and they get worried, oh, is that blood? Well, it typically begins about 1/3 away from the subependymal region. So where the thalamus kind of starts here, the groove, typically 1/3 away of the size of the thalamus is where the Cory Plexus begins. So if you see any echogenicities here at the caudothalamic groove, is blood. If you see any echogenicities beyond the thalamus, it's the Cory Plexus. And here is another patient that had a grade 1 hemorrhage. Right here where the arrows pointing at, you got your subependymal hemorrhage, thalamus, caudate nucleus, and this echogenic blob right here is the bleed. And this baby was 31 weeks and weighed exactly 1,500 grams. Well, after the clot begins to resolve, cystic areas are left in their place. So these clots, these blood clots undergo cystic degeneration or liquefaction, and cysts are left. So this patient had a bilateral grade 1 bleed, and they started to undergo cystic degeneration after about a week. You can see some little cystic areas here, but this one's obvious right here on the right. Grade 2. Grade 2, the subependymal blood breaks into the ventricular system through the wall. And it fills the ventricle with blood without causing any ventriculomegaly. Sometimes the blood makes a cast of the ventricle. So here you can see lateral ventricle, third ventricle, and all this is blood. All this is blood, and this is also blood. So this is a germinal matrix area. It's all blood. It breaks in through the ventricle, and it fills the ventricular system with blood. And also, you can see how smooth this brain is. Very premature neonate, probably like 24 weeks, maybe even less. And here is a sonographic image of the bleed. So here are your lateral ventricles, and within the ventricle, you see this echogenic lesion right here, which is blood. You don't see any on this side. You see some echogenicities here, but that may be reverberation artifacts. And then a sagittal image of the ventricle shows the blood is filling almost the entire ventricle. And then this same baby, we scanned serially over a couple of months. And you can see this is the blood at the beginning. Then as the blood clot begins to retract and liquefy, you can still see here's echogenic here, is more sonolucent here. And then 2 months after, the ventricle is clear. This is the Cory Plexus, but there's still an old echogenic blood clot right there attached to the Cory Plexus. But as you can see, the baby never developed any hydrocephalus or ventriculomegaly. Grade 3. Now, a grade 2 is once it breaks into the ventricle and fills the ventricle with blood. Grade 3 is the same thing, but causes the ventricles to become enlarged, ventriculomegaly or hydrocephalus. So it's an IVH with ventriculomegaly. The ventricular lining can become echogenic over time, reflecting chemical ventriculitis. Once the baby has a grade 3, they have a 20% increase in mortality and a 35% increase in neurological deficits like learning impairments, developmental delays, maybe even cerebral palsy. And this is a very large lateral ventricle. It's filled with blood. There's some blood here as well in the contralateral ventricle. As you can see, it never broke through into the parenchymal tissue. The cerebral cortex here is very thinned out, but there's no blood within it. It probably would eventually develop if the baby survived at grade 4. And then here you see a grade 3 lateral ventricles. You got the anterior horn, body, occipital horn, temporal horn, completely filled with echogenic blood. So this is still liquefied blood as it hasn't hardened into a clot yet. And then here you have some clot. This baby was 34 weeks gestational age and 1927 grams. So it didn't fall into the less than 32 weeks and less than 1500, but still developed a grade 3 hemorrhage. And then over time, the ventricle lining became echogenic, showing ventriculitis from the blood products in the ventricle. And you can see here the cast of the blood clot with the center of the blood clot more sonolucid than the outside areas. And then the ventricular megaly. This is actually another baby with the grade 3 bilateral. This baby was 29.2 weeks and 1,150 grams. And the same baby 6 months later, you see all the blood clots have resolved, but the ventricles are still enlarged. They're not very enlarged, but they're enlarged. And then you can see the developmental brain showing many gyri and sulci. Okay, grade 4, which is obviously the worst bleed. It's intraparenchymal bleed. In this gross anatomy section, you can see there's blood within the ventricles, and then there's blood within the parenchyma. After the blood retracts and liquefies, a cystic area will be left behind in its place, which is sometimes called cystic encephalomyelitis or a poor encephalic cyst. And that cyst will fill with cerebrospinal fluid and sometimes will connect to the ventricular system. So it's considered a white matter venous infarct. CSF fluid will fill the cavity at the end result, which is encephalomyelitis. And premature infants who get grade 4 bleeds have a 50% increase in mortality and a 90% increase in neurological deficits. So these typically will become patients that have cerebral palsy and diplastic quadriplegia, or, they typically have very, very poor neurological outcomes. And here you can see a 27 gestational week baby with a large intraparenchymal bleed. You can see it's causing midline shift. You can see the hemispheric fissure here is being pushed over to the left. And then a sagittal view showing the extent of the bleed. It's taking up a lot of cerebral tissue here. And you can see here the ventricular lining. It's already showing a communication with the ventricle. So once this heals, a big cystic area that connects to the ventricular system will be there. Here's another baby with a grade 4 on the left. So here's your right side, right lateral ventricle. And then here's the paraventricular white matter on the left. Increased echogenicity. Here is a parasagittal view. Then at 2 weeks, you're going to start seeing cystic areas forming within the ischemic area or infarcted area. See the ventricles are a little large. There may be some midline shift here. And then over a 4-month interval, you can see the large cystic area that's left from all the destructed brain tissue. So the brain tissue dies, it infarcts and necroses, and all those blood products will liquefy. And here's connected to the ventricular system. And here's a sagittal view. So this is a large area of cystic encephalomyelitis. Okay, here's a progression of a grade 4. I don't have the data for the age of this baby, but you can see by the smoothness of the brain that it's very young, probably 26 weeks, maybe less. You can see the sylvian fissures. All right, so on day 1, there was no bleed. On day 2, there was still no bleeds. By day 3, remember I said by the first week of life, all bleeds form. A large clot can be seen right here. Looks like it's taking up some of the ventricle and some of the parenchymal tissue. By day 4, there's a big intraventricular clot, and then there's also a big area of periventricular echogenicity consistent with ischemia and necrosis. By day 7, you can see some of the blood clot retracting and becoming sonolucent. And then by day 28, a lot of this has become hypoechoic. We have no other imaging on this neonate after this baby passed away. All right, so one of the common complications of intraventricular hemorrhages is post-hemorrhagic hydrocephalus. So it results from the obstruction of the ventricular system by blood, septations, or debris. So any byproducts of the blood too can cause a mechanical obstruction down below by the fourth ventricle or below the fourth ventricle. And the trigone and the occipital horn are the first ones to dilate. The incidence in surviving infants with germinal matrix hemorrhages or intraventricular hemorrhages is 15 to 22%. And in 50 and 75% of these babies, the ventricular dilatation resolves by itself, or at least slows down. And 15% of those babies will require some intervention in the future to reduce the ventriculomegaly or hydrocephalus, like a VP shunt or a reservoir. Okay, now we'll move on to hypoxic ischemic injury. It is a major cause of morbidity and mortality in neonates. The estimated prevalence of these conditions are 2 to 4 per 1,000 live births. So 2 to 4 out of every 1,000 babies born can suffer some form of hypoxic or ischemic injury. In some cases, when this happens, the sudden and drastic redistribution of blood flow to save brain tissue can lead to multi-organ failure. Typically, the first ultrasound that they order on babies who have had any hypoxic event is normal. Though sometimes with high frequency transducers, you should pay attention to the basal ganglia, and you may find some increased echogenicity areas there, but it's not very specific. Follow-up ultrasounds show echogenic lesions, which progress to cystic encephalomyelitis. One of the common findings is periventricular leukomalacia, which is sometimes termed as white matter necrosis or white matter ischemia. The periventricular white matter, as I told you in the earlier video, is typically somewhat echogenic, though it shouldn't be more echogenic than the Cory Plexus. So any increased echogenicity around the ventricles should warrant monitoring sonograms to prove that PVLs don't develop. Typically 2 to 6 weeks after the discovery of PVLs, cystic changes start to take over, and the brain tissue that has died is replaced by tiny cysts. And in these patients, they typically have significant neuromotor impairments. All right, so here we have a baby. On the initial exam, you can see there's increased echogenicity of the brain seen throughout. There appears to be effacement of the sulci, and there's echogenicities within them. And there's also a loss of cortical differentiation from the white matter to the gray matter regions. In 10 days, you can see the entire brain is increased in echogenicity, and now ventricular megaly has developed. And then within 2 months, you can see the cystic changes throughout the cortex, all around the ventricles. This is another baby born at 25 weeks gestation and weighing 720 grams. So very tiny. On the initial sonograms, you can see there's slightly increased periventricular blush, though this can be normal, and we typically see this on normal babies. But on the following sonograms, you can see that the echogenicity increases with cystic formation. And the cysts just increase. And then here's some sagittal views of the same days. So on this image, it looks absolutely normal. You have a very premature brain, smooth, Cory Plexus, anechoic ventricular fluid, and the periventricular white matter does not seem to be increased at all. And then on the following sonograms, you can see increased linear striations consistent with infarction or ischemia, and then cystic changes that proceed. One thing you can notice on this baby, the smoothness in the brain and how the gyri and sulci begin to develop over time. So here's another one, baby with hypoxia. On the initial sonogram, there is increased echogenicity throughout the brain. There's a smudgy appearance to the brain with loss of cortical differentiation. Severe destruction of brain tissue, ventriculomegaly, and there's increased subdural fluid all around, pushing the left hemisphere of the brain all the way down as well. And here are the cystic areas within the brain parenchyma. And sometimes when there's a focal vascular insult, you'll have a cystic space left behind, as I said before, is known as encephalomyelitis. So here you can see the cystic area with some retracting blood clot. This patient on the other side also had some PVL. And then several months later, you can see the large gaping cyst that's left behind. You don't really see any small cystic changes here, but the resolution of this image is decreased because of the size of the baby on the follow-up exam. So to differentiate between cystic encephalomyelitis and PVL, PVLs are usually unilateral, though they can be bilateral, and they're usually focal, whereas PVL will be more global, all around the ventricle cystic spaces. And has a Swiss cheese kind of appearance.